bend to your wishes, of course.
I think we share it, Mark.
Okay.
People get fed up of my voice all the time, so I think we share it.
Okay.
So first of all, I'd like to welcome everybody here this morning. As you've just heard, Mark and myself will jointly chair this meeting. It's a lovely sunny day, so I propose that we belt through the agenda. You may ask questions, but please remember that other members would like to ask questions as well. So don't be over excessive with some of the questions that you ask. Mark?
Thank you for that. And Croeso, welcome for me too. It's good to see you all and to have this opportunity to engage with, respond to any observations, concerns, interests that the Community Health Council have, be their role to be accountable to you and to respond accordingly. Before we come on to the agenda, Jackie, can I just mention one thing, please?
Certainly.
Okay. Some of you, if not all of you, will have seen the press coverage of the last few days concerning an investigation that has been taking place at Wrexham Minor Hospital and which is focused upon the care for the elderly ward, Morris ward, on that scheme. I clearly can't say much because, first of all, the police were engaged in the investigation at an early stage. There has been an arrest. There has been a suspension of a number of staff. And as you would imagine, there's been close liaison between the police and ourselves about the conduct of, firstly, the criminal investigation, what will become, no doubt, a professional standards investigation. I just want to say that no matter what, I would hope you recognise that the allegations are appalling, and Joe and I and others on the health board recognise they are appalling, and we are determined to ensure that the investigations that are now underway are, of course, thorough, that they go to the heart of the matter, and that they are, when concluded, transparently reported upon at the end of any criminal or professional standards proceedings. We are also engaging with other bodies other than the police in terms of the work that's required in terms of those investigations, and no doubt subsequently. So I just want you to hear from me and from me and Joe how serious we regard the matter and how important we regard it that we get to the bottom of this as soon as we can. You will know that there have been previous concerns in this type of service previously. Those concerns are very well documented. I have seen concerns being raised by the Talvan Families Group on Twitter with that in mind, and it will be our intention to ensure that we engage with that group, ideally with the support of the CHC and Jeff. And I know that Joe and Jeff have spoken about that this morning, but you know, it remains our commitment, Joe and I, to be as transparent as we possibly can in terms of all such circumstances, and to, when the moment is right, to report openly on what was discovered or not discovered and what actions are being pursued as a consequence. So if you don't mind, Jackie, I'll stop there because, as I say, I'm very limited about what it is I can say, and what I can say was very much reflected in the press releases that have been issued on the matter. Joe, is there anything you wanted to add?
Not to the substance, Mark, of what you said, but just
Joe, you're frozen.
She is in an office not far from me. Let me just run across and speak to her. Hold on.
It's just the
Sorry about that. Jo has frozen. She's dialing back in, Jackie.
in the meantime,
sorry, go on.
Chairman, could I just say that I think the statement that we had, both from the police and the longer statement that we had yesterday from Betsy Cadwallader, I think that puts it in as much detail as is appropriate at the moment. What we don't want is actions being prejudiced by too much publicity. On the positive side, Betsy Cadwallader reported this to the police and to the other authorities that Mark has alluded to very early on, as soon as was practically possible. I can confirm that we're also in discussion with Jill Harris around meeting with the Talfan families and hearing their concerns. I think these events were triggering for them. John Stewart, who many of you may know, tells me that yesterday, when the news broke on the BBC, he had phone calls from Talfan family members that he hadn't heard from in a number of years. I think it would be a good thing for the health board to reach out to those families and to hear what they have to say. Their experiences are still relevant 9 years on.
Thanks, Jeff. Is Jo with us yet, Mark?
No, she's not. She was just going to give a personal endorsement in terms of what I'd said. So I'm going to suggest we just move on, Jackie.
Yeah, that's fine. Thanks, Mark.
That's fine. Yeah.
Apologies for absence, Mark. We know we've sent ours to your office, so we can take our apologies as read.
That's fine. Can I welcome Hugh Evans to the meeting? He has joined the board. He remains as a member and leader at the moment of Denbighshire County Council, but he is with us. So, Hugh, you might want to say hello.
Yeah, morning everybody. Thank you, Mark. Really looking forward to joining the board. I've got an awful lot to learn, but I'm determined to learn pretty quickly. Yes, still a councillor in the middle of elections at the moment, but hope to stay as long as I can. So thank you.
Thanks, Hugh. Nice to meet you. And I hope you enjoy your time on the board.
That was it for me, Jackie. So I'm happy to move on if you are.
Right. Declarations of interest. Can I ask members attending this meeting today if there are any matters of interest to them that they declare? If anything crops up during the meeting, if you could let us know during the meeting so that we can log your declaration. Thank you. And we go on to the draft minutes of the joint meeting that was held on the 21st of October. I'm not taking them for accuracy because they have been checked by both Mark Collin and the CHC, and we are happy with the minutes. So I propose that we go on to a review of the actions. Are you happy, Mark, to take that one?
I am, thank you. Yeah. Unless you correct me otherwise, Jackie, and I'm always prepared to be corrected by you, there are no actions listed from those minutes.
No, that's fine then. Thank you, Mark. So we'll move on to the agenda, and the first item on the agenda is a COVID update by Jill Harris.
I think it's Nick.
And I believe Nick is doing this in Jill's absence, yeah?
Yes.
All right, thank you, Jackie. Very happy to do that. I will bring in Teresa, if I may, for some of the testing expertise, and Sue for some of the staffing areas. I wonder whether my screen sharing, unfortunately, is greyed out and doesn't appear to be working. I wonder whether, Chris, I think Philippa sent you the presentation. Are you able to screen share? You are a superstar, sir. So if we then move on to the second slide, I think it shows that we are now living with COVID, and the coronavirus is something that is going to be with us for a time to come. And whilst those graphs show in some areas, a downward trend, which is very welcome, it is still very much a real issue for our patients, our staff, and the health board. And testing, which previously I could offer an opinion and begin to understand, now because of the change in testing regime, is quite a complicated area to interpret. So if we move on to the next slide, Teresa, whilst, Chris, thank you. Whilst the slide does show some improvements, Teresa, don't think that tells us the full picture, does it really? Are you able to give your expertise on the next couple of slides?
You're correct, Nick, completely. Bore da, everyone. No, you're correct. We've now moved into a testing space where the focus is on symptomatic individuals. I think most colleagues on this call will be aware that the mobile testing unit elements and much of our support which came through the Department of Health and Social Care has now been reduced because of that focus on symptomatic. And therefore, when you look at the testing figures, what was normal before with people attending for testing and using LFTs is now in a different place. The guidance for individuals has changed indeed. And so it is no surprise that the graphs are showing the decline as they are. So it's quite hard to understand the full picture of transmission, although we are trying to use all the other signals that we can see as a surveillance system in Wales. And so we are focusing on some of the Office of National Statistics testing, which has been going right through the pandemic, and also the wastewater surveillance, which is also perhaps helpful. And of course, we continue to watch hospital admissions and admissions in the system in general. So I agree with you, Nick, we need to take some caution as we look to those graphs. And maybe the main message for today's meeting is that we probably need to, as we move into the new world, we will be taking a different view to surveillance and actually probably need to wean ourselves off that daily surveillance that we've become used to. That's probably all I was going to mention, but certainly from my perspective, we still have high rates of transmission, but the graphs and the epidemiology data that we've all got used to at the moment isn't keeping up with that because of the change in our approach. Thank you, Nick. Diolch.
Nick, you're on mute.
Diolch, thank you. My apologies. If we move on to slide 7, going through the intervening slides slowly, Chris, I think these slides just show what Teresa has been expertly describing for us. And then when we get to the vaccination slide, vaccination, of course, is absolutely still going to be a central plank of our COVID defence. Many of us, I think, triple vaccinated have succumbed to COVID in the last few weeks. And whilst it doesn't have the same horrendous effects for most people at the moment, vaccination is going to be what keeps us going. So the additional booster vaccination programme for the elderly continues. I don't know whether, Teresa, do you want to horizon scan and guess what might happen for us in the autumn and going into the winter, or would that be pure speculation?
Gosh, there's a question, Nick. My crystal ball probably isn't quite in that space. For me at the moment, the focus has to be on the spring booster. All now the people who are eligible for spring booster should be getting the letters in the next 7 to 10 days. Aiming to complete that programme, I think mid-June is probably the indication that we have. As for going forward, I increasingly see this programme becoming part of our natural vaccination programme as a health board. We've probably got a few years where we will be learning about what's best, the best approach, which groups. But certainly from a health board perspective, the lead for us at the moment, Graham, has been working with the vaccination team and looking at how we can deliver this programme alongside our other programmes, because flu is as important, if not more important at many times. But we've also got all the measles work, the MMR, shingles for the older population. Those are our normal populations, including HPV. I think we've always been quite thin in how we've provided that work, in that at times, you know, people have taken it on top of their additional workload. And I think this is an opportunity for us now to really take vaccination seriously, provide the best service that we can, and the team are working through that planning now to see how we can optimise the system. So I think my crystal ball is rather cloudy this morning, Nick, so maybe I should stop there.
Thank you, Teresa. But it does make it hard for the planning, doesn't it? Because, you know, traditionally in primary care, one was very aware of what the coming winter would bring. One would plan for one's staff to be able to vaccinate because of the uncertainties, but the direction that Teresa is pointing, I think it does make it harder to plan our vaccination programme going forward. And of course, staff who are involved in vaccination are not doing something else that they might otherwise be doing within the health board. So quite a complex system to manage. If we then move on, Chris, if it's okay, Jackie, Mark, stop for questions at the end. Would that be all right?
That's fine.
Nick, Joe's got a hand up.
Apologies, I can't see hands.
Just, if I may, to provide some assurance on the delivery of the current programme. Our care home residents are nearly completed in terms of the spring booster programme, and we've been really pleased with our uptake, our mobile uptake for residents of Betsy who are over 75, and indeed our housebound citizens, around 40 individuals per day, are being vaccinated through that connection to providing vaccinations at home. We've got, for all eligible individuals, call and book an appointment at any time and any centre offer going, and we've used mobile testing units in our more rural areas. And we're just working through for our younger population, those who are 12 plus. We're identifying those and calling those at the moment. We're a little bit dependent on a Welsh Government process to help us identify those individuals. So not crystal ball gazing for the future, but just to give you a quick update on how we're going with regard to the spring booster programme. Thank you.
Very grateful. Thank you, Joe. And moral to myself, never upgrade your Zoom app just before a meeting. Just struggling to cope a little, my bad. Richard, I noticed you've asked about why the vaccination figures for Anglesey are so low. Teresa, I'm not able to answer that, but we can go back to Richard outside. Have you got any insight?
I'd have to double check, Nick. I haven't got that data at hand.
So Richard, we'll get back to you if that's okay outside the meeting. If we can then move on, the COVID occupancy slide that's in front of you now shows that whilst you might feel an optimism from the overall rates you've seen a few minutes ago, COVID is still a very real problem for us in all of our acute sites, which is what you're seeing in front of us, but also in our community hospitals, our dental surgeries and our GP surgeries, and a very real present problem to manage as patients navigate through our hospitals. And if we move on to the next slide, you can see that those are hospitals which are still very busy, very pressurized, and leading not always to the patient experience that we would hope for, despite the incredible dedication of our staff. Where one is a hospital status, which at this time of year, as the sun starts to shine, as we were talking at the beginning of the meeting, we might sometimes be seeing. You'll see that our hospitals are often at a 3 or a 4, up there in the orange and the red. A situation replicated across Wales, across the United Kingdom, but one that is further challenged by those COVID numbers that still sit in our hospital beds. If we move on to the next slide, you can see that that whilst a number, the blue are the patients who have, we believe, developed COVID within the community environment, there is also transmission within the health board. So those COVID numbers in the hospitals and the pressure within the hospital flow, that this demonstrates the real challenge for our staff in protecting our patients and indeed our staff as we learn to live with the COVID virus. Moving on to the next slide, Chris. And this is perhaps where there is some grounds for optimism, where we can see that actually the number of patients who are admitted to critical care, where they're having breathing problems as a result of COVID, is now incredibly small. Still there, and tragic consequences for those individuals sometimes who are still affected. But it is increasingly the case that patients are in hospital with COVID rather than in hospital because of COVID. And those who are in hospital because of COVID are much less likely to be admitted to intensive care. Nonetheless, catching COVID is still a very unpleasant experience for many. Moving on, this again, looking at that level 3, level 4 status within our hospitals, this is looking at the other end of the flow within the hospital, showing the number of patients who are awaiting discharge out from hospital. And again, COVID testing, COVID positivity, ensuring we protect patients in our community hospitals, in our residential and nursing homes, is part of the reason for some of these delays, as well as during the staff sickness, those who are assessing and caring for patients outside the acute hospital setting. If we can then move on, Chris, if we may, and again, sorry, further demonstration of the fact that COVID is present not just in the acute hospitals, but again in our care homes, remembering that these are a particularly frail population where COVID can have more devastating consequences. Chris, if we can then move on. Primary care, we feel is probably being affected disproportionately by COVID. Many on the call today probably will have had COVID in the last few weeks, despite being triple vaccinated. And some of you will probably have had to consult your GPs. So primary care, both in terms of staff sickness, but also patients seeking telephone advice, needing home visits, or needing to be seen in the practice with all the infection control conditions that are required, is really putting a pressure on our primary care facilities. Mainly GPs, but also, of course, GDPs, our dental colleagues. So I think it's very easy when talking about COVID to concentrate on our hospitals, and that perhaps is the focus in the first and second wave. But as we learn to live with COVID and as we plan for the future, general practice, primary care is in many ways bearing the brunt of our COVID at the moment. Moving on then, Chris, if we may, and Sue, I think you're on the call. Are you able to guide more expertly than I through the workforce slides? Although I suspect the take-home message that it's an incredibly difficult challenge managing workforce with COVID. Sue, are you with us?
I am. Thanks, Nick. So I wouldn't propose to go through the slides because A, they're very detailed, and B, as with everything, they're immediately out of date because we see different trends with COVID. I think one of the take-home messages is that it is challenging managing the balance between being able to offer the best and the safest care and being able to keep our staff safe and manage some of the complexities of COVID as well as other reasons for sickness. We are seeing, but we've seen this a number of times, another reduction in the levels of absence linked directly to COVID, but we are seeing some increases in the levels of absence linked to non-COVID. But the trend in terms of some of the staff numbers, and I think if we go through the slides, the trends that we were seeing were starting to level off. So I think it's the next slide. Yes, so we can start to see that is starting to reduce against all reasons for absence, which is a good thing. But as you can see from that graph, and I think the graph after that, We've seen this go up and down over the period of time. My hope would be, and what we're anticipating, given some of the trend evidence, is that will continue to move on a downward trend. From a COVID point of view, what we and other organisations are really anticipating, though, is the potential that we will see further increase in some of our other absence, and particularly those absences linked to stress-related absence or chronic fatigue, which I think we've been building plans in anticipation of. So I wouldn't tend to go through them in minute detail, but the take-home message is it is challenging. It is challenging as well because it fluctuates. We are now starting to see more of a downward trend, and the hope would be that we'll continue to see that in terms of COVID-related absence, but we're not complacent by any stretch of the imagination in making sure that we're continuing to keep people safe. Thank you.
Thank you, Sue. So if we're able to flick through the remaining slides, which demonstrate in the detail for those looking keen on seeing the detail to exactly illustrate what Sue's just been sharing. Chris, can we stop sharing the screen? Would that be all right? And then Jackie, Mark, happy to take any questions. Apologies for quite a canter through, and apologies again for my personal Zoom issues this morning.
Right, I'm having difficulty, Mark, seeing the screen at the moment. Who's asking questions? Can you? That's better, I think. Nobody's got any hands up that I can see. Mark?
No, I can't see any either. And the chat question from Richard has been responded to by Nick. So no.
We have the regular, usually weekly, update on the COVID situation, and our members get that as soon as it comes out. So they are pretty much in the picture as regards progress on COVID.
The only thing, Mark, that I would add, and I'm being asked more frequently now when I go into the town or the village, because they know what I do, is when are we getting our second booster? And I'm talking about the 70-year-olds, the 65-year-olds. Is there anything in the pipeline for those people, or is this one that we're going to have to wait for Welsh Government to come at us?
Thank you, Jackie. So the letters for the particularly vulnerable and the elderly, I think, as Teresa said earlier, will be going out. Whether in the way this has happened in previous booster vaccination waves, that will then cascade down to people of lower age and lower risk, time will tell. But letters for some of the more senior people within our society and some of our more at-risk patients will be going out over the coming days and weeks.
Yeah, I think that's what's caused the concern in the community, because those letters are already out there and patients in those groups are already getting the vaccine. So I think that's why people are asking the question now about their age group. Joy, you've got your hand up.
Yeah, can I just ask about the numbers of people who are out of sync, of which I am one, people who had their vaccines late, people who maybe haven't yet been vaccinated. And from my perspective, as somebody who had my vaccines late because I was on a trial, I've heard absolutely nothing about whether or not I should get a booster, when I should get a booster, or anything. And I'm just one. And I know it's a small percentage, but you've been having people going for their first vaccination, their second vaccination, and we just seem to be this lost pool who have to be proactive to go and get ours. But working on the basis that some of these people were vaccine hesitant, if they're not actually asked, they won't go.
Thank you, Joy. I can't answer the specific. I can assure you we will look at that and get back to you outside of the meeting. Unless, Teresa, you're able to fill in that detail, but I suspect Jill, as subject matter expert, will be the person who will be able to answer and isn't with us, Joy. But thank you for raising it. Teresa, outside the meeting, back to Joy.
Thanks, Nick. I don't think I have a specific answer for you, but certainly the letters are going out. I'd like to think you're not the forgotten group, because it is a big group of people who've been involved in a number of the trials, and we really must support those who have been vaccine hesitant, because supporting them to maybe take the vaccine will make a big difference. And we do know that taking the vaccine, if it is late, is still helpful. So as Nick said, we'll take that back to the team. For me, we're following the JCVI guidance, that's where the team are, but if we can improve communications, we'll continue to work on that one. So on the specific, nothing more I can say, I don't think, but I'll link in with the team with Jill not here today.
Thank you.
Thanks, Teresa. Hugh, you've got your hand up, so we'll take the one last question from Hugh on this topic.
Thank you. In terms of the overall vaccination programme, I can appreciate the difficulty of how that is planned, and how we do plan for the next 3 months, 6 months and 12 months. But that said, even though it's difficult, is there an intention to have a vaccination plan for the next 12 months in order to plan the resource and capacity required to deliver and make it more effective?
Thanks, Hugh. I think, as Teresa said, front and centre of our thinking, and as we move into a vaccination programme, perhaps more akin to flu than to the emergency response, if you like, that was there during the rollout of the vaccine less than a year ago. Gosh, doesn't time fly? But it is challenging because some of the guidance comes out with an expectation, quite rightly, that we respond very quickly. So very much, plans will be formulated, but the uncertainty that I've described and Teresa has described more expertly than I makes it very difficult to give us, an absolutely robust plan. And we will have to continue to be fairly reactive and agile as we go.
Teresa, yes.
Thank you. I was just trying to help, and Nick, you'll be aware, we've also got the Strategic Immunisation Group. We call it SIG within the Health Board, which is where much of the vaccination discussion has happened over the years to plan all the other programmes. Of course, COVID we've treated slightly separately to make sure that we got the vaccination through in such big numbers, let's be honest. What we're trying to do now as a team is bring it all together. So we do have an immunisation plan. What we're now doing is adapting and updating that one so it becomes a vaccination plan, including COVID, because that is such a big programme. So I'd like to assure Hugh and colleagues that that planning is in place.
Thank you. Thank you very much, Nick, for the information that you've given us this morning. If there's no further questions, I'm going to go on to the next agenda item, which is CHC Visiting.
Chairman? Yeah. North Wales CHC, along with other CHCs nationally, ceased visiting in March of 2020. Normally we do 400 or 500 visits a year. It's something that North Wales CHC members took very seriously. And that actually fed into your quality improvement programme. There are a number of links, and it was something that was valued by Betsy Cadwallader Health Board as well. That stopped in March 2020. We have been waiting for an opportunity to restart. We thought we had one in the autumn of last year, but then we had Omicron. And we thought it was advisable not to proceed. We've been in discussion with Jill Harris about restarting visiting. We've been in discussion with our own members. Some members still very wary about these activities, but other members very, very keen to get started again. We started middle of last month with a series of visits to adult psychiatric and older persons mental health wards. And the basis of those visits are that the people undertaking them were symptom-free, that they were all announced, and that we don't feel it's appropriate for us to visit any area where friends and family cannot go. Willing to take lateral flow tests in advance of the visits, although that hasn't been required, but we are willing to do that. And members wore masks and followed appropriate social distancing rules. Those visits went well, I think, and we will extend them further as we move on. We still have a significant number of members who feel it inappropriate to visit at this time, and we respect that. We have other things for them to do. But so far it's gone quite well, Chairman. It was you and Joy that did the pilots. Do you have any comments?
Yeah, they were pretty well received. We would have liked to have actually visited more of the wards, but the visits that we did do we were well received. Your staff give us a lot of their time. We've got quite a few things that we will be feeding back to you and also to Jeff and Carol when we do the final report. But we felt extremely safe during those visits. We didn't feel at risk at all. And your staff were wearing masks just like us. So for any of the members that want to do these sort of visits, Joy and I, after doing the pilot, are willing to go out tomorrow, if you like.
Yeah. And you should add all members who went had been vaccinated.
Yeah, totally. So, Joe, you've got your hand up.
Thank you, Jackie. We have always welcomed the important role that the CHC plays with regards to visiting, and we really support the risk-based approach that you have taken to reintroduce visiting during this COVID time, acknowledging all of the important considerations for your CHC colleagues and our staff and patients with regard to keeping them safe. We are just in the process as an executive team of reviewing our visiting policy, and likely to be considered at our exec team meeting next week. And if we move in the direction that we in the direction that I think we will go, that will increase by definition, Jackie, the numbers of areas that we think we may be able to then consider for general visiting, and obviously then for your own attendance in review visits. So we'll be in touch, Jeff, Jackie, Carol, once we've finalised that review next week. Thank you.
Thanks, Joe. Thanks very much. And Teresa's just put something on the chat, and thanks for that, Teresa. We will keep you informed of everything.
Can I just say, Jackie, how welcome your visits are?
Thank you, Mark. That's appreciated.
It's a clear responsibility in terms of your remit to carry them out. We expect you to. We take the feedback you offer us on those visits, of course, very seriously. And I'm sure the staff who have been under considerable stress, as you well know, very much appreciate you and your colleagues giving up your time to do what you're doing, particularly in terms of those visits. So I say on behalf of the health board, thank you very much.
Thank you, Mark. Just as an aside, we felt this time especially the staff welcomed us because we were an outside body that they could kind of pass on comments to, that they'd bottled up, nothing detrimental, but we were like a safety valve, if you like, that they could talk to us about, and we felt very, very welcome by them. So it was good. And we listened to the staff, which is what I think they needed at this time.
Thank you.
So thanks for that. Do you want to go on to the next one, Mark?
Yeah, that would be good. So keep us moving forward. So the next item is targeted intervention. We thought that you would appreciate an update in terms of where we are in our response to the targeted intervention framework and the expectations set out in there. So we'll keep it relatively brief, but of course it's an important topic that we wanted to update you on. Joe, I'm not sure because Jill's not here. Who's picking this up?
So our colleague Simon Evans has just joined the meeting to take this topic. Thank you, Simon. Diolch yn fawr.
Thank you, Bore da, everyone. Let me share the screen so that you've got the slide deck in front of you. Hopefully that is now working. Can we all see that?
Yes, that's fine.
Okay, brilliant. So thank you. So just want to start with the current position. So as you know, this is Welsh Government identified the 4 areas. We identified the improvements within those 4 areas, and we're trying to meet some of the outcomes that the Welsh Government defined in the framework. We started this journey about 12 months ago. The board does a 6-monthly self-assessment, and we're just about to have our self-assessment at the next board meeting at the end of May. But we started with 0s and 1s. Within 6 months, we'd moved to 1 across the board, and we'd set a target across the of high 2s in everything other than leadership to be a 2. So just a point on the scoring system, if you like. First one is where it's just a number. That's where we think we've got evidence of action. So we've done what we said we'd do, and we're calling it a high where we've got evidence that action has had a positive impact. And I think it's a very, very, very important distinction. I think the other thing to say is that a high 2 on a scale of 1 to 5 sounds like about halfway, but it isn't. So Welsh Government have defined what each of those stages are, and level 2 is defined as early progress. So I describe that as green shoots of recovery. It is saying that we've got sporadic bits of good about the organisation. There's a massive jump between 2 and 3. So 3 is talking about results, and 3 is talking about much more consistency. So at a level 2, even at a high level 2, there will be pockets of good, but equally there are still many areas that still need an improvement. So although high 2 sounds almost halfway through a 1 to 5, in practical terms, it isn't. And just to cover off really some of our internal governance and external oversight, because this is a self-assessment process. So we've got the operational teams that are doing the doing. We've got a central check and challenge process that checks on them and their evidence. We've got evidence and outcomes groups that look at have we done what we said we would do, and has that made an impact? And we invite external members as well as members from around the health board to provide a check and challenge for that. There's a steering group that reports directly into the board, and the board itself does the self-assessment. And I'm really sorry, I put the wrong date there. It's the 26th of May, 19th of May is when we're meeting the Welsh Government for our regular catch-up in terms of TI. But the self-assessment will be done on the 26th of May. We've also got an organisation called the Good Governance Institute, which works across the United Kingdom within healthcare and other sectors, and does exactly what it says on the tin in terms of good governance. And they're having an external view of our processes to make sure that they are strong and robust. So given that we're about to move into the self-assessment bit, I thought it would just be useful just to talk about some of the improvements that we've seen across the patch, some of the things that we're doing. So in terms of CAMS, and this is really in the partnership space, what we're trying to do is create a no wrong door strategy, bringing together the needs of children and young people, co-producing this with partners and our young people themselves. And the aim of the strategy is to move towards a sort of no wrong door approach to respond to children and young people's emotional well-being and mental health needs, and just to ensure that wraparound of multi-agency services around them. Again, in the partnership space, CAMS and our neurodevelopment services are leading the development of a children's charter, again in partnership across North Wales, really to start setting standards that as organisations we can work to make sure that children and young people are treated fairly and have a voice. And again, massively want to include young people in that. And you can just see from these first couple of examples that these domains, although separate, are absolutely intertwined. And you know, we can't really move forward in mental health without linking back to the leadership and the engagement domains and strategy domains as well. They're all absolutely intertwined. We're doing quite a lot of work to make sure that we can use the data that we've got intelligently, use benchmarking intelligently to help us improve services. And in adult mental health, you know, there's been a lot of work with the Ligature Risk Reduction project over the last eight months or so, and we're really seeing the outcome of that now, reducing the risks across our estate and services. In terms of strategy, planning and performance, I think this is a demonstrably exciting time. We, for the first time in 5 years, have developed a 3-year plan, the Imtp, which is clearly a requirement of a health board to have a balanced plan over that period of time. And by changing our approach to planning, changing our approach to service redesign to be more transformational, more engaged, aligned to a consistent way of introducing improvement across the organisation, we've got to the point where we do have an Imtp, we do have what we think is a robust plan that we will be able to follow over the next 3 years. We're waiting for colleagues in Welsh Government to sign that off for us. In terms of the leadership domain, there's an awful lot of work going on here, which I'm sure you'll be familiar with. We've got an ongoing board development programme. We've got new independent members that have joined, and we want to make sure that our board is as strong and united as it can possibly be. I'm sure you will have heard the Stronger Together message, which has been a massive conversation that we've had with our staff and others in terms of how we organise ourselves, how we live to our values, how we operate the organisation, and we're about to finalise a new operating model that in many ways allows decisions to be made as close to the patient as possible, which is fantastic. And one of the things that's come out of that is a people strategy. You know, ask our people how they want to be managed, how they want to be supported, and that feeds through into the people strategy that we've got. We've got many examples of good engagement that have happened across the health board, either centrally or within pockets. We're getting better at actually using the data and the feedback to inform service change. So I think one of the areas that I'm pointing to is the long COVID and that clinical service development of how to deal with long COVID, which, you know, is a relatively new condition that we need to look at. And we're involving patients who have managed to, we're involving patients in developing that pathway. And some of the suggestions in terms of, you know, linking in mental health as part of support processes, we're putting in. So actually having the conversation and listening and doing something as a result of it. Again, in the partnership space, we're looking at carer experience and how we can support carers, play a vital role in healthcare. We're looking at trends and feedback of the themes and have set up a nutrition and hydration improvement group to focus on improving nutrition standards in patients at the miler. So that's also developed diabetic posters for the emergency department and share positive and negative experience with wards through the sort of traditional "you said, we did" sort of approach. We've got bite-sized health and wellbeing virtual events which are routinely taking place. We're strengthening our links with Black and Asian and minority ethnic communities. We regularly attend sessions of the North Wales African Society and the Chinese Association. You'll be aware that we've big engagement through Living Healthier, Staying Well, and the feedback from that is also helping us to form the clinical services strategy, which is currently in development. We've also recently had our 4th annual stakeholder survey, and that again is showing positive feedback for us in terms of improving relationships with our key partners. That is just a really quick run through of some of the things that we're doing. I think again important to note that we've got the self-assessment coming up at the board meeting on the 26th of May. I think we're probably in that 2 zone where we set the targets. But just a note of caution that 2 isn't close to halfway through our journey. 2 is early progress. It's setting the foundation stones. It's showing that we've got pockets of good that we need to expand across the rest of the organisation. That said, happy to take any questions. Or I know around the table we've got the SRO leads of each of the domains, so I'm happy to take any questions.
Can I make a comment, Jackie, please?
Yes, certainly.
So we discussed the latest evidence in some depth at a workshop quite recently. And of course, it's important that we get the assessment right and we gain the assurance that we need, both as executives, independent members, and together as a board, around our assessment of where we are and what's required to move forward. As Simon's referred to, the next set of assessments are due in May at the public board. But suffice to say, at the workshop the other week, it was good to see challenge being laid down by the executives in terms of the assessment scores that were being suggested by those who've been gathering the evidence. And also by the board more broadly. So at this point, whilst they may be the target scores for May, as Simon has alluded to, I think there is some concern about whether we are going to achieve the targets that have been set. The important thing, though, is that we follow the process, that we apply due diligence, we seek the necessary assurance, which starts with the executives as the SROs and then on to board. And as I say, it was good to have a somewhat rigorous discussion at the workshop, aided by the executive team member contributions. It was good to see the challenges that they were laying down themselves. So just a heads up that we might not be the scores for May as predicted in this presentation, but if we don't, there will be a legitimate and sensible reason for that, as you would expect, and based on due rigor.
Thanks, Mark. I appreciate that this system must be rigorous and that evidence and outcomes must be checked thoroughly, because we want to see improvement. And if you don't meet the timescales, so long as you're progressing in the right direction, that to me is positive. I wouldn't like us to endorse or even look at something that you'd skipped over in order to meet those targets. So I'm pleased that you are being as rigorous as you are over them. Any questions for Simon? No, thank you very much, Simon, for your presentation. It's appreciated. And I expect this won't be the last time we hear you speak on this subject.
Probably not, dear. Thank you very much. Have a good rest of your meeting.
Thank you. We'll go on to speech and language therapy.
Yes, Chairman. This was another one in our safe space events. Safe space events are, we've held them virtually, we've held them face to face, and it allows people to share their experiences, their concerns, their plaudits around a particular service. This one, the speech and language therapy services, was done as a mixture of virtual and face-to-face. In the BBC article that followed, it said that it was a CHC probe. It was not. It was something that was done in full cooperation with the speech and language therapy services. Gareth and colleagues invited us to come in and do it, and were very supportive all the way through, and we're really very pleased to have the report, and they're working on implementing changes that were flagged up as part of the report. I think it's fair to say it would have been a very, very different report had we not had the pandemic. Where we had a small number of people contacting us about things like stroke and support from speech and language therapy following laryngectomies and so on. And they were very positive generally. The overwhelming number of contacts were in relation to speech and language therapy provided to children with language development needs. And because of the pandemic, those services stopped on a face-to-face basis between March and September of 2020. And I think it's fair to say that this was a disaster for some of those children. The therapy is delivered at a crucial stage in language development, and best benefit is had at particular stages. And those children missed that out. And not only did they miss that, they missed the opportunity to develop their language skills with peers at school and friends and family. And I think it's yet another dreadful outcome of the pandemic. When the BBC interviewed, I'm not sure whether it was a chief executive, it was somebody very senior from the Royal College of Speech and Language Therapy. They said that this was a common experience across the UK. It was not unique to North Wales. The other thing we heard was, as we hear from many services, that once people were in the service, they very much valued it and appreciated the service and thought it was really good. The adverse comments we had beyond, my child lost these services for a period, were around the interface between education primarily and the NHS. And parents would expect a seamless service, but they're not really interested in whose responsibility things are. They expect a seamless service. And for various reasons, they weren't getting that. There were a relatively small number of those, and we were able, for those individuals, to get together with Gareth and his team and solve some of the problems. But some of them really relate to the interface between education, social services and health, which are probably beyond team members' remit and control. It was a very useful piece of work to do. We enjoyed it very much, and we particularly appreciated the positive support we had from Gareth and his team.
Thanks very much, Jeff.
Gareth is here, so I don't know if you want
Gareth, do you want to come in?
Yes, thank you very much, Diolch yn fawr. Yes, I'd just make a couple of comments if that's okay. I think the first thing I want to do was just re-emphasize the purpose of this, why we did it. We, as a service, were very, very keen to hear from our users and the carers of our users in a lot of the cases in regards to children, because we want to improve the service. That was very, very much the motivation, and still is the motivation. And I would reaffirm the commitment that we've made publicly, which is that we will use the learning that we can extract from the report to do just that. And the teams are busy working on that now, and that will become part of our COVID recovery plans for speech and language therapy. What we were effectively presented with was a set of patient stories, a series of patient stories, and they have a particular depth and richness, I think, to them that provides a quite unique opportunity for learning, the sort of opportunity you don't often get from other bits of intelligence that we have about how a service is performing. So we were also very keen to test out how we do this better, and I think this exercise has provided some wider learning about how we would use patient stories and direct patient experience to drive improvement as well. So from that perspective, it's been extremely valuable. I thank Jeff for some of his kind comments about the service. I would just perhaps return the compliment and say that Jeff, Carol, and the team have done a great job on this. I've noted from sort of slightly arm's length just how much capacity it takes from them. It's quite time consuming, so I thank them for that. And I thank them also for their professional and collegiate behaviour all the way through this. And as I say, I think there's some broader learning for other clinical services about how we might use patient experience and patient stories to drive improvement. Thank you.
Thanks very much, Gareth. No further comments. Jeff has posted on the chat where you can get a copy of the speech and language report. So Mark, over to you.
Thank you. So we'll now move on to the integrated medium-term plan, which Chris is leading on. Thanks, Chris.
Thank you, Mark. I'll just project my screen. Just bear with me for one moment. Perhaps if somebody could just shout out to confirm you can see it. Great.
That's fine.
Thank you. Okay, so I'm going to quickly canter through the slides, and then I'll pick up any questions at the end. Our integrated medium-term plan, what is an IMTP? Well, essentially, the IMTP is the mechanism by which we take the NHS Wales planning framework, which is the Minister's direction to NHS Wales in terms of the Minister's priorities, and then personalise it to our contexts in North Wales. And you'll see there a number of documents. There's the ministerial priorities in the planning framework. There's our targeted intervention framework, a Healthier Wales document, which has been with us now for a number of years, and colleagues in this meeting will be familiar with that, along with Living Healthier, Staying Well, which colleagues will also be aware of, and then the North Wales population needs assessment to hold us true to our North Wales environment. And we take those and other sources of information and guidance and create a plan for how we as an organisation look to deliver against those expectations, ostensibly over the next 3-year period, but mainly focusing upon the immediate year in front of us. And we refresh that document then each year. Within our context here in North Wales, as Simon mentioned earlier, this is our first official 3-year plan. Previously, as part of special measures, we were required to submit annual plans. We're now in targeted intervention and are moving to submitting the 3-year plan, which we have now done. It would be remiss not to draw out the current COVID-19 challenge, whilst it's not as it has been in the last 2 years. It still remains a very active part of our lives and is an active part of our considerations as we plan forwards. And I've touched a little bit upon targeted intervention, and it's really important that as part of our plan going forward, that we actively, proactively draw out the expectations within targeted intervention and show how we will and are addressing those. And Simon ran through those a little earlier. The next 2 slides talk about how we have cut our plan this year. And I feel that this is quite important, and we've made an active move from cutting the work of the Health Board in vertical slices to cutting it into horizontal slices. And let me explain that a little bit further. If you look in our annual plan last year, you will see that we talk about prevention, and then we talk separately about primary care, and then separately about secondary care, and then a little bit about tertiary care, which is where we refer patients on to specialist hospital facilities generally. The difficulty with that, of course, is that we all experience those challenges at those interface points, and we spend so much time discussing where episodes of care have fallen apart or not been as well managed as they could have been when people have moved through and across those interfaces. But it's more than that. Besides the fact that that presents a really difficult experience for our patients, our public, it actually makes it very difficult to move resources around within that picture, and it means that we often have too much focus in one part of that jigsaw and not enough focus in other parts, and it really doesn't help us in meeting the ambitions that we have as an integrated health board. If I come as an individual with a particular condition, I might want to move along the pathway of management for that condition in a seamless way. I might want to have as much of my care delivered by my local service as possible, but knowing that it's much easier to get enhanced care when I need it, and then quickly fall back to my normal standard of care in my local community when that's all that I currently need. And so we're starting to talk as an organisation about pathways of care, and how when we devise or revise a pathway of care, we make absolutely sure that it's balanced, and that we're putting the right amount of effort into prevention, into those early interventions that make a really big difference, and hopefully then result in less people needing the complex care that we might previously sometimes have been a little bit over-focused upon. You will see when you look through our IMTP that we are very much talking about that integrated pathway journey now, and we are not talking about separate, almost silos of care delivered in primary care, secondary care, or in the other areas I touched upon. And it's really important in our shift of organisation, a really important part of our journey through targeted intervention. We can't pull together an IMTP, submit it, and have it approved if it is not balanced. And balance immediately brings to mind balance from a financial perspective, but balance is about more than just the finances. We could put together and submit a plan which is balanced on a financial spreadsheet perspective, but which is built upon recruiting lots of different professionals who we simply know are not out there to be recruited. So it has to be balanced across all of the other aspects of resource too. And we believe that our plan this year is, and we've done much more work in terms of understanding balance in the journey that we've been through over the last year. So just running through the key components of the IMTP, and the full IMTP is on our website. There is the core document, which outlines our general approach, our priorities, and a glossary of terms within the IMTP. And then there are a number of appendix supplements. Now, the first just draws the alignment to the ministerial priorities to help show where the threads run through everything that we wish to do going forwards. And the second talks about planned care recovery, which is a really important part of our plan within the context of COVID. And it's an area of our plan which I will touch upon in a couple of slides' time. An area of our plan where there is still further work underway as we all move from this position of pandemic into a position of learning to live with COVID. And the third appendix goes into greater detail than the main document in terms of why we've picked the priorities that we have and what we expect them to deliver, and when they will deliver and how they will deliver. We have a separate supplement for the first time this year in terms of workforce, and that really refers to the conversations I've just made in terms of ensuring the plan is balanced in all ways. We have then talked a little bit about years 2 and 3 as best as you can, looking forwards. And as we move through this year, we will be producing a more sharpened view of next year's plan. And we'll then refresh the document moving forward and introducing a new year 3 as the plan moves forward year by year. We have taken a logic model approach this year. I think when you look at the logic models, the reason for that will become clear. But what logic models are there to do is to transfer activity, things that we will do, things that we say we are going to do, and translate them into how that makes a difference to the individual accessing those services. There's absolutely no point making lots of changes and introducing lots of new things if they don't make a difference to those people who are choosing to access services. It absolutely has to make a difference to our population, and the logic models demonstrate that. Finally, then, the last appendix just links to the many documents that have informed and will continue to inform our planning as we move forwards. My almost last slide, I think, then just outlines our risks. Our approach going forward is not risk-free. It wouldn't be right to put forward a plan that was risk-free, and nor would anybody believe us if we said that, because the NHS has never been in a more challenging environment than it currently is. In terms of key risks, they are similar across other organisations in terms of financial risk, and the implications of other waves of COVID, for example, and the implications of picking up the waiting list backlog. They're challenged in terms of workforce. We believe our plan is reasonable from workforce, but it is still a very unpredictable area in some places. And then I touched upon planned care recovery and how we move forward in terms of picking up the backlog of activity that has accrued whilst we've been in pandemic environments. So my last slide, in summary, the plan that we have put forward is balanced against the resources that we have available. It is appropriately ambitious, but not overly ambitious, but not underly ambitious either. We have very much prioritised our direction against our local population needs and against our organisational needs, recognising that we're in targeted intervention. And we've created this document in partnership, and I put this as the last point in my slide, really, to remind me very much to thank officers in the CHC who have contributed in our journey to producing this IMTP and who have therefore made it a much richer document. So thank you very much for that. That's the end of my presentation, but I'm happy to pick up any questions.
Thanks very much, Chris. I've got a question that I asked 10 years ago when I first became a CHC member, and it was around population needs. And do we take into account when we do these plans the potential increase over the counties through a sudden influx of housing developments, etc., that weren't planned 5 years ago, but all of a sudden the UDP has put these things in place. We've also got things like the Ukrainian situation now, which will provide more housing and needs within the community. Is there a caveat or a contingency around any of the planning that takes a sudden surge?
Thank you, Jackie. Yes, so one of the documents I referred to was the North Wales Population Needs Assessment. And that's not a document that we produce, but it's a document that in partnership through the RPB we produce, but very actively contribute to. And it is clearly an important document. And what that does in part is try to make some of those predictions moving forward. Now, some of those areas, such as the demographics of an ageing population, are relatively predictable. And we might not be absolutely sure where different forms of housing are required exactly, but we can make some general and reasonable predictions. Of course, when the latest iteration of the population needs assessment was written, we didn't know about the Ukrainian crisis. So some things, and that's a perfect example, will sort of land left field and would not be taken into account. But we would factor that in then as we move forward and refresh those documents.
Thanks, Chris. Joy, you've got your hand up.
Yes, I've got 2 points to make. It's great to see you're doing the continuation planning, the patient journey planning, rather than isolating areas. And one of the things which impacts hugely on that continuation is good IT systems. At the moment, your IT systems are a total mess. Nobody can talk to anybody. They're still getting handwritten reports scanned and attached to emails. We are so far behind the rest of the UK in this. And when you do seem to have a system that works, suddenly you decide to change it. It's just one huge, and I know it is an enormous project, but it is such a crucial thing for the people in the community, the workers in the community, to actually be able to access patient notes when they're not in their centres, for members within the centres in the community to be able to access patient notes from the GP or the DGH or whoever. And even within the DGHs, there seem to be multiple systems running, so they can't even talk to each other. It's just, from what I've seen and what I've heard from staff and patients, it's one huge mess. And it doesn't appear in your IMTP.
So I was going to agree with you, Joy, until you just made the last comment, because it does appear in the IMTP, and it appears quite large in the IMTP, and it also occurs in our digital transformation plan, which also underpins our IMTP. Absolutely recognise the issues that you refer to, and I think we all do. It probably would also be a good time to point out Dolan, who has joined our senior team now and reports directly to the Chief Executive, because we absolutely recognise the important role for digital going forward. So we recognise absolutely that there is both an opportunity to improve some of the fractured IT, but also to move it forward in much more innovative ways than has previously been the case. And if you can't identify the respective parts within the IMTP, I'll be very happy to pick up a personal conversation with you to move it forwards.
Brilliant. To be fair, I've only seen your presentation. I haven't read the IMTP in detail, but it is an area that I would say should be one of your top priorities.
Absolutely agree.
The other thing I wanted to raise with you was workforce planning, and you get sideballs that you don't expect. For example, the new change to the NHS pensions, and I'm aware that a number of staff are going to be retiring who potentially wouldn't have retired had the pension not changed. Now, some of them may come back on the new pension arrangements, but not necessarily all, or they may come back part-time. And those are the sorts of things that can throw your workforce planning a curveball. It's not your planning, it's central, but it's going to have a huge impact on your workforce planning over the next year.
Again, we would recognise that there are curveballs such as the ones that you have just outlined that that we have to deal with, and certainly Sue, our Director of Workforce, has that very high on her mind, as we all do. I guess we have to deal with those curveballs as they arrive, and it makes the importance of planning that much more important, doesn't it? And again, if you look in the IMTP, you will see how Sue's team have moved forward our approach to workforce planning to try to mitigate or fully address some of those issues. Sue may want to pick that up, but again, very happy to continue that conversation offline if that helps.
Thanks, Joy. Adrian?
Yes, thank you. I'd just like to reinforce what Joy says about the IT system. It is terrible here. The Royal College of Physicians called it ineffectual, and it has to be a priority for the health board. And I think it's something that we need to dissect out. I mean, at the vascular meeting yesterday, the imaging wasn't assessed by one of the surgeons that resulted in a catastrophe. So I do think it's got to be a priority of the health board. It's only if you get adequate data that you can actually plan your health care properly. And I don't think the health board is up to doing it at the moment for planning. We've taken ages to get any vascular figures out because of the way it's all recorded. So I just really think it's my ode to Joy. Thank you.
Thanks, Adrian.
Jackie, can I suggest that Dalan be invited to comment? He has just joined us, as Chris referred to. And be assured, as Chris has already said, it is a priority, but perhaps Dalan.
Yeah, thank you. Yeah, so just to introduce myself, I'm Dalan Roberts. As I've put in the sidebar, I think Chris picked up what I was going to say fundamentally. The health board definitely sees sorting out the digital and the IT as a priority. I think that's been part of my appointment to the board to address those issues. I do appreciate it's quite a significant challenge that we need to take on in that regard. Although I'm only 9 days in, it's quite evident that there are some gaps. And my intent is to do some quite deep discovery work, really, just to understand exactly where we are with the myriad of our IT systems and our data repositories, and then come up with a plan from that point on. And in particular, very importantly, making sure that's aligned to the work that Chris is doing in terms of around the IMTP.
Thanks, Mark.
Thank you, sorry. I think it's fair to say too, and I'm sure this is recognised, of course, not all of this was within our gifts. There is a national IT programme that you'll be aware of. I do agree that we need to be more influential on that landscape, and Dylan and Joe will share that view, I know. So there's an opportunity there for us to get more rigorous and also to act as a better testing ground. But there is a need for national as well as local solutions that we will seek to ensure occur as best we can in terms of the influence that we have. But I can see Joe wants to come in.
Joe?
Briefly, because of time, I was able to have the opportunity to escalate the issue of the lack of availability of a single patient administration system across North Wales with the Director General and Chief Executive of NHS Wales yesterday. So please be assured, working through our own systems and processes and working with our All Wales digital partners, we are extremely keen to make sure that it is as easy as possible for our patient records to move across our system, as well as making it as easy as possible for our clinicians to access the information that they need to provide safe and appropriate care. Joy, thank you very much for raising the question, and Dylan, thank you for on day 9 picking up a response. Thank you.
Thanks, Joe. Sean, you've got your hand up.
Yes, just one question. Well, not just a question, really. I've gone through the slides again, Chris, and the end-to-end pathway of care built around need. Was that not always there with patient-centred services?
So the ambition was always there, Sean, and absolutely, if you're going to be person-centred, then how can it not be?
Yeah.
In practice, of course, you still do see those fracture lines when you move from one service to another. And as CHC members, you will all have stories to tell where people have fallen between services when their care has been transferred. So we knew and continue to know that there are other ways in which that can be done. And taking that end-to-end pathway approach is an approach which other organisations have made really good progress with. And it reminds us that actually all of this is about the person accessing the services, not about process. And it reminds us that if we move some of our resource to different parts of that end-to-end journey, we can often get far better results. So that's the reason that we've made that conscious and very visible move.
I guess from my point of view, I'm thinking, are you just retitling things that, you know, and we'll be back with a new title in 5 years' time because it hasn't worked again. So it's just one of those things, isn't it? But thank you for answering that.
Thank you, Sean.
Thank you, Sean. Thanks, Chris. Thanks very much, Chris. A difficult subject and quite a few comments on that one. And again, we'll be keen to see how it develops over the coming 3 years. Mark?
By way of ending, can I just say though what's this a significant step forward it is to have been able to deliver an integrated medium-term plan to Welsh Government. It is the first time that that's been achievable, certainly in the time that I've been in position. It has required a lot of hard work on behalf of the executive team and board members and those who report to the executives, but I'd like to acknowledge the work that's gone into that. Of course, the responsibility now rests with us to deliver what's in the plan, and I can assure you the board is intent on doing so. But it is a step forward, and the level of integration between priorities along with finance and also workforce is key and is much improved compared with what you will have seen last year. Thanks, Jackie.
Thanks, Mark. I'm going to move on to the next agenda item, which is the clinical strategy. I believe, Nick, you're taking this one.
Thank you very much, Jackie. Chris, can I use your skills to drive us through this? I won't, if it's okay, Jackie, go through every point on every slide, but just to provide a kind of an overview of perhaps what the clinical strategy, clinical service strategy is, and what it is not. This is very much if we move on to the second slide, Chris, very much a blueprint for services that provides that strategic direction. It builds locally on living healthier, staying well, which I'm sure will need no introduction to colleagues. It builds on our own population needs assessment, but it also integrates with key national documents, a Healthier Wales, the National Clinical Framework, and also the other documents that are outlined on the slide in front of you. But for me, if we move on, this has been a development within the Health Board, which, considering what the staff have been dealing with during the pandemic, I've been so grateful for the engagement and the enthusiasm during the 4 workshops, the formation of a clinical senate, clinical colleagues working together really to provide feedback and challenge and brainstorm ideas to develop this blueprint for our strategic services. It's not a complete document, and you see it today. I was going to say the ink is still wet. It's not all written, and that's rightly so, because the engagement now starts with CHC members, with wider staff, and with our partner organisations, and that engagement plan Helen and colleagues are working up as we speak. It has been seen by the execs and the independent members that across the board, and it's growing as we speak. In fact, the version that you're seeing is slightly out of date. If we move on then to slide 4, this is, I won't read it out to you. This is so important. Going back a slide, it is all about the building a clinical vision to create a healthier North Wales, to commission and provide excellent person-centred care, and to empower our staff to transform and innovate. And then moving on to the slide in front of you, you've got some guiding principles and some basic principles. I think we need to get those. We need to get those titles a little bit clearer, because already identifying some confusion that they bring. But these guiding principles, I think, are really important. It does need to be person-centred. That blueprint doesn't need to be ground on our existing clinical way of doing things. It needs to be grounded on the population we serve, to be outcome focused. It needs to be designed with them, the engagement that now starts. It needs to look at the needs of our population, not necessarily just our historic practice. It needs to focus on keeping people well, getting further up the pathway to intervene at earlier stages to promote wellness, rather than focusing at the acute hospital end of that scale. And it needs to be driven by accurate information, something perhaps we've already touched on, and we need to ensure that we use that information and we use it wisely. So then moving on to the next slide, some more principles in front of you, that we can't just continue to do things the same. We need to transform and to innovate. But we also don't need to just use acute hospital beds. We need to be giving care in the right place, and giving good quality, excellent high quality care across all of the Health Board the population that we work with, and we are there to support and empower in their health. And it's not just a Betsy thing. Healthcare, it clearly relies on a number of partnerships. So that collaboration and those partnerships we need to value and be engaging with as we get these principles behind this blueprint refined and right. So then if we move on, at the risk of stating the obvious, but sometimes it's important, I think, that these documents do state the obvious, because otherwise it can get forgotten, that our people are absolutely key to this. And we need to support them to do what they want to do, which is to work differently. Our estates are absolutely vital. And I think we're all aware of the estate strategy and the work that needs to be done. And we've already touched on digital, so I won't go there again, but this is perhaps some further encouragement that that's in there and recognised as key to our strategic direction. There are some design principles then that we have adopted, and do need to think about our titles here. And whilst these may appear very basic, may appear perhaps even obvious, I was quite surprised, humbled by talking to our staff in some of the workshops at how emotional they felt and how reassured they were to see some of these statements beginning to emerge at this stage of the clinical services strategy. Primary care, rightly up there, that's where the majority of care is given, and we need to really consider how we use that resource to its very best. Community hospitals, we need to value. We are very privileged in North Wales to be able to have the community hospitals, and we need to think how we use them to their very best effect. Our acute hospitals, this was the bit that really surprised me, is the, no, perhaps surprise is the wrong word, it was staff's reaction when we were making commitments to have 3 acute hospitals in North Wales, Isby, Gwynedd, Glenclwyd and the Wrexham Myler, all providing emergency care. And obviously that is key to our development of that blueprint. And the regional treatment centres, which I won't talk about at length, are absolutely key to our long-term planned care recovery. If we then move on to the next slide, we're talking about how we will deliver services across those 3 acute sites, our primary, community facilities, and looking at some services may lend themselves to a network solution, a hub and spoke model, and others need to be planned or delivered perhaps in a different way. And mental health care is perhaps a prime example of the complexity and difficulties of managing some of our services. Specialised services, of course, delivered outside North Wales will always take place, but this blueprint actually provides perhaps some clarity as to which services might at some point in the future be able to be brought closer to home, be brought back into North Wales and delivered on a more local basis, that care closer to home, right care in the right place. And we mustn't forget the Medical and Health Sciences School, the power of that and the huge potential of that to transfer our clinical services and improve the sustainability of our clinical services in the longer term. So I think the next slide talks about some of the criteria, including detail from the National Clinical Framework. I won't dwell on that, but happy to take any questions. Very important that we align ourselves with national guidance and that national clinical framework. Perhaps then, just as we move towards the end of the presentation, just draw your attention to the blueprints that we need to be that the strategy will include. There'll be appendices to help us in our quality impact assessment, checklists when we're considering any change in the way that services are delivered, to ensure that our teams and all of us on the call today can ensure that any decisions are made in line with our commitment in this emerging clinical services strategy. with a very strong framework. And if there is an overlap with Chris's presentation on the IMTP, I make no apologies for it, because that's absolutely right. This integrates with the IMTP, and as we've seen already with our other strategic documents. So just finally, and then happy to take questions, this is has already been developed at pace. Yes, long overdue, but now moving at pace. And over the next 3 months, that engagement work will both start and continue, but leading by the end of July to a submission at the Health Board for formal approval of the clinical services strategy, to be that blueprint to do what we need to do for the population that we serve. Jackie, Mark, happy to take any questions.
Thanks very much, Nick. It's quite a lot to take in. I would personally like to suggest that we put this topic on one of our service planning meetings so that we can read your presentation and get a list of questions and perhaps look into it a little bit further. A lot of work has been done around this, and a lot of work will continue to be done around the engagement side. And I wouldn't like to be flippant at this point by asking questions that I'm not conversant with or would appear to be ignorant of what you're trying to achieve. So I would like us to take this, look at it, and perhaps put it on a service planning agenda.
No, thank you, Jackie. Although I'm sure no question would be ignorant, but we're very welcome, both in that environment, but also, questions and suggestions direct to myself and the team in order to inform the development of this.
Thanks, Nick. Joe, you've got your hand up.
Thank you, Jackie. Just with your permission, may I also offer Helen Stevens-Jones to be part of that conversation with Nick from the point of view of our engagement approaches as well. I'll leave that thought with you, and we're more than happy to field whomever you think would be most helpful for you. Thank you.
Thanks, Joe, and I appreciate the offer and happy to accept Helen's input into this. And I'm sure I'll talk to Jeff and Carol about it, and we can sort out an agenda item for the service planning. It doesn't look as though we've any questions, Mark. There's no hands raised.
Did Sean have a hand up, or should we put it down there? Might have been an old hand.
It was an old hand.
Okay.
Can we go on to vascular services? Again, Nick, I'm sorry, it's you. I don't mean that as it sounded.
Thank you, Jackie. Very happy. And Chris, I'm begging your indulgence yet again. I will learn how to do this with the latest version of Teams. Apologies, colleagues, because I was struggling to think through how much detail to provide. Some of us have walked this path rightly in a lot of detail, and this provides just a very high level updates that have taken place since the last board-to-board meeting. So on the next slide, you just to remind us that the hub and spoke model centralized on Glenclwyd Hospital was implemented in 2019 in line and after extensive discussions with external societies, including the Vascular Society and the Royal College of Surgeons. The board in 2020, we will recall, invited the Royal College to carry out an invited service review, and they've provided a number of recommendations in their reports of March 2021 and more recently in January 2022. That has led, along with the outputs from national audits, the National Vascular Registry, and incidents and our own learning, has led to a huge amount of work from our teams in the vascular improvement plan, which is overseen by the Vascular Steering Group. And thank you to CHC colleagues who only yesterday, sat with me on the Vascular Steering Group. And I'm really grateful for the challenge, the support, the discussions in that group, making sure that our vascular improvement plan really leads to improvement and not just completion of an action plan. So on the next slide, we see some of the recent actions. We're very happy to take questions, and we've seen closer working with our regional tertiary centre, the Royal Liverpool University Hospital Foundation Trust, who will over the coming, already are, and will over the coming months work more closely with our consultant vascular team and our wider vascular service. And perhaps a particular focus of work around the quality of our note keeping and consent. Adrian, I know where you're going to go with this in terms of the need for us to digitalise, and that is central to our longer term development. But in the meantime, that urgent need to record on our current paper records and consent and discuss with patients in detail, as those discussions clearly must happen. We are actually piloting the first rollout of the digital health record is currently being piloted in the vascular service, but with some considerable success. And I received an update from the team leading that this morning. If we could then move on to the next slide. We'll be aware that we've convened a vascular quality panel to review 46 sets of notes, 47 sets of notes that the Royal College of Surgeons themselves reviewed in 2021. That quality panel has now met and is chaired by a well-respected national lead, Susan Aikenhead, and she, with a team of both internal and external experts, is going through those notes, making sure that we fully explain to patients and their families of what's happened and where there may be a need for further treatment, ensuring that happens. And I'm really grateful to Susan and the team for that incredible amount of work. Not an easy task to go through those notes, but very important that we are open with our patients and that we ensure that they are updated on the care that they have received over recent years. It's my sad duty also to report two Never events that colleagues will be aware of that happened in the service in March 2022. And whilst very fresh in our memories, we have put immediate make-safes and enhancements to our service in the short term, while further service improvements take place. That includes increased support from the Royal Liverpool, as well as a doubling up on some parts of our consultant rota. That's not sustainable in the long term, but those improvements will remain in place until May the 23rd, and will then be reviewed to consider whether they need to be extended or not. So then, if we just move briefly on to the last slide, just to reinforce a huge commitment of Betty Cadwallader, the Health Board, to these improvements, very close oversight at committee and board level to ensure that the plan is prioritised and effective, closely working with colleagues, partner organisations across Wales, and can I again reiterate my thanks to CHC colleagues who sit on the vascular steering group. Jackie, apologies, I hope that wasn't too much of a whistle through, but I didn't want to inflict detail on you that you're already aware of.
Yeah.
No, thanks very much, Nick. I'm going to bring Jeff in if I can.
Yes, Chair. As you know, it's something that's on every one of the CHC meetings, every one of the our services planning meetings. I had the opportunity to speak with Susan Aikenhead, and we had an extensive discussion about the history and how we got to where we are. I know that Richard and Richard Bladen, who is a service user, and Adrian, our Vice Chair, are closely involved with this. We had a meeting, the Chair and I, with minister a couple of weeks ago, and we were concerned about the difficulty in recruitment, and we were disappointed with the response we got. We believe that the situation we're in now is something that should be addressed jointly between BCUHB and Welsh Government. It's a very unusual situation. The problems are very difficult, and we had hoped that there would be
more support.
More support. I think support is from Welsh Government is vital, and it needs to be real support. Disappointing. Adrian?
Yes, I agree with you entirely, Jeff. I think it needs to be a support from the Welsh Government to improve the service. And Mark was saying earlier about Welsh Government having an important part to play in the development of IT, for example. And they need to take ownership of this, and the Health Board needs to go to the Welsh Government and make sure they are aware that they have this responsibility for the patients here. I don't really think I need to say anymore. It's a slow process, and I think improvements are being made. But time will tell, and when we start visiting again, we'll be able to see the impact on patients.
Thank you. I can't see any more hands up next, so if you want to respond. Am I on mute?
No, we're on.
No.
Yeah.
Nick, did you want to say anything else? Jackie's asking.
Sorry, I dropped out for just a moment. So, Jackie, if there was a question, I missed it, but, but otherwise.
No, there wasn't really a question. There wasn't really a question, Nick. I was just asking, did you want to respond to Jeff and Adrian's comments about involving Welsh Government?
I think what we were saying, Nick, was that we believe this is, whilst we understand that day-to-day running of the Health Board, and to a great extent future planning, is rightly the responsibility of the Health Board and not the Minister. This is not a usual situation. And we felt that we were disappointed that there wasn't more recognition of that, and that we feel that more joint working on this particular problem, which is intractable and difficult, needs to be coming forward.
And thank you, Jeff. And I would highlight that there's very close working with Welsh Government colleagues, for which we're grateful. In particular, perhaps a network community beginning to emerge between South Wales vascular services and ourselves, really trying to share best practice. But again, I want to reiterate our thanks to you, Jeff, and to Adrian.
And we welcome, by the way, Nick, the links with Liverpool. We think they're very, very positive.
Yes, very good.
Thank you. I can't see any further hands up next. So once again, thank you very much for your presentation. Mark, over to you.
Okay, so we've got two updates, which we'll take together if you don't mind. We'll deal with urology, and we'll also deal with a HIW report into YGC emergency department. And it's like you, Jackie, I acknowledge Nick's involvement again, because he's taking this too. So we're working hard. Nick?
Thank you very much. Thank you, Mark. Thank you, Jackie. So if we move to the urology first of all, then I've already referred to the expertise of the Royal College of Surgeons in an invited service review of vascular. And in view of our need as a health board to be absolutely sure that we are driving the right improvements in developing the urology service across North Wales, as needs to happen, we have invited a similar mechanism, an invited service review of urology. That's likely to take place in the late summer or early autumn, and we're currently working with the college to ensure that that visit is successful, well informed, and helps us as we need. That's not to say that we aren't doing anything at the moment, and because clearly following Ombudsman investigations that are highlighted, we will all be aware of, we're already, there is a urology improvement group. Jill, who isn't with us today, provides chair expertise to that, and has really brought together the consultants, some of the nurse specialists, the operational team, really to look at the current action plans and begin to drive the improvement there. We do have patient representation on that improvement group, and I've been really quite humbled by the quality of the discussion and the need and acceptance to drive that improvements. We do have problems. We don't have a strong clinical leadership, and perhaps some of the issues that we've seen in our vascular services, we've looked very carefully at our vascular learning plans, and to see whether some of those may be replicated within our urology service, and indeed some of the areas around note keeping, the quality of our multidisciplinary team meetings that we've seen in vascular are also to a greater or lesser extent present in our urology service, and that's been able to inform our development. We recognise that we need more managerial leadership and response, and the urology network manager is currently being recruited. But it's not all, you know, there is some exciting stuff happening. Urology is right at the forefront of research, and particularly over at the Myla in the east of our North Wales. We're seeing some very exciting research initiatives taken forward. And the robot, you would have seen the minister using the robot at a ceremony last month, I think, and our urologists very engaged with other clinical colleagues into bringing robotic surgery for urology into North Wales. So huge opportunities, absolutely no room for complacency, and a need for us to develop the quality of services. And we are working very hard ahead of the Royal College visit to North Wales later this year. Mark, would it be useful if I pause there to take any questions before moving on to the ED topic?
It would. You may have seen the exchange between Joe and I this morning, and Joe's asked about the delay in terms of gaining an experienced team from the RCS to undertake the urology review. I think that's fine, Nick, providing that those actions that you've described that are already underway are, in your view and Joe's view, sufficient and can provide the necessary assurance to the board in that regard.
Yeah, thank you, Mark. We could have, as Mark said, we had an option for the college review team to arrive either very quickly and perhaps a slightly less experienced team, or to wait for some very senior clinical advisors, and are taking the decision, working with the college, to wait to get a really robust visit, and that's likely to take place late August, early September.
Jackie, I can't see any hands up unless you can.
No, I can't see any more.
Right, Nick, YGC ED reports, please.
Thank you, Mark. Colleagues may be aware that there has been an inspection as part of the continual visiting process across the emergency departments. HIW have visited Ysbyty Gwynedd and have more recently visited YGC Glenclwyd. In response to that, we have also brought about our own internal visit to the Wrexham Myla ED to ensure that we really understand what's happening in all three of our EDs, our emergency departments, and driving improvements in them. We are yet to have the formal public announcement and sharing of the findings of the HIW visit to Ysbyty Glenclwyd, so you'll understand that I can't go into all of the detail, but suffice to say that perhaps it's highlighted areas around note keeping, around working closely with patients to ensure that we're always identifying patients whose condition is deteriorating, and those are issues which have previously been highlighted in other reports. So a huge focus, and thanks to our leadership team in Glenclwyd for taking that forward, and for working with national quality team who've been visiting Glenclwyd over the last couple of weeks to really bring some focus and speed to those improvements. There is now a weekly meeting between the hospital management team in Glenclwyd and the clinical executives, and I join Jill and more recently Gaynor and Gareth with those visits. And we are continuing to work closely with HIW to ensure that the actions are as they should be. More importantly, I think we are holding the mirror up to ourselves to make sure that those actions are as they should be to do what we need to be doing for our patients. Happy to take any questions, Mark, but recognising the report hasn't yet been made public.
I know Joe wants to come in, so I'll come to Joe first, Nick, if I may.
Thank you, Mark. Just to supplement Nick's response, mentioning regular meetings with the with the executive team, the leadership team at YGC. We have recognised that there are a number of issues at play at the moment with regard to YGC, and so we have provided additional support to colleagues in YGC to enable them to be able to start to or continue to put in place improvement actions that are being identified, some of which have a similar theme across a number of areas. So whilst we acknowledge there are challenges, it's very important that we provide additional support for the organisation. We're also fortunate to work with colleagues called Improvement Cymru, who are a Welsh government improvement agency, and they are providing additional support, particularly associated with YGC emergency department service improvements. Thank you.
Thanks, Joe. Jackie, I can't see any hands up, so are you happy to move on?
Yeah, I'm happy to move on, Mark.
Okay, so we then come on to the Stronger Together update.
This will be a double act between myself and Sue. Sue will share and I will speak. Thank you, Sue. I'm very conscious of time, and so I will take these slides as read, if that is okay with you, Mark and Jackie. But there are a number of slides that I would like to particularly emphasise, and then I'll pause for questions at the end. So if you could take us on to the next slide, please. So the reason to speak to you about our operating model work is to build on the conversations we had with you earlier on in my tenure about the importance of taking some time to listen and speak with staff, leaders, IMs, partners within the organisation about what we do well in Betsy and what needs to improve. And the work associated with a programme of activities called Stronger Together is drawn very heavily from that process of early engagement. It's really easy for a chief executive to come in relatively new now to an organisation and think, I already know what this organisation needs by way of improvement. I would always prefer to take the time to understand the organisation and to understand the particular challenges that Betsy face. So I'll talk a little bit about where that conversation has taken us. Next slide, please, Sue. The discovery work, which is a fancy name for talking to a lot of our staff, partners, leaders, and managers, told us that we needed to make sure that all of our staff were clearer about our organisational purpose and our goals. That whilst we do have 5 organisational values, the behaviours that underpin those values, which go to compassionate care and a value for patient experience and staff working together and so on, do need to be developed. So when we talk in Betsy about our first value, putting patients first, we're clear what behaviours would underpin that value. We also had feedback that we need to improve our engagement and communication as leaders with the organisation, and staff wanted to be clearer about their own personal contribution to health and wellbeing within the population of North Wales, and to make it clearer for staff to understand how that contribution counted. Healthcare these days, of course, is a multidisciplinary process. So to create conditions to make it easier for staff to work together as their natural way of being, to try and bring decision making within governance frameworks as close as possible to the front line for patient benefit and for clinician effectiveness, to be more focused on our leadership and development, to simplify and clarify our organisational structure, which is complex, to create additional skills and capacity to drive change and service innovation, and to enable individual and teams' contributions to be recognised. That's a large programme of change. And moving on to the next slide, Sue. This conversation right now is focused on one aspect of that change, and there's lots of work going on around the other aspects of change, including reintroducing our staff empowerment, our staff acknowledgement and awards events later on in the year. Next slide, please. All of this work fits within the people strategy and plan, which in turn links into our integrated medium-term plan. So there's a strong synergy. Next slide. So when we talk about our operating model, I'm essentially talking about how we organise ourselves as an organisation to deliver services for our population. Next slide, please. And when we were thinking about what should drive those proposals for change, we co-designed and co-developed with our staff a series of principles that we would use to help us make choices about the structure within which we think we should be able to work more effectively. Next slide, please. So this is where we are thinking at the moment, that we build on our existing West, Central and East place-based systems, enabling us to connect effectively with our local government partners, non-statutory agents and other partners at a place-based approach, acknowledging the differences and the synergies across all of North Wales with regard to population and service delivery, but that we do create an integrated approach to all healthcare, from self-care, prehabilitation, into all forms of primary care, and then into community hospital and acute hospital care. And we feel that will enable us to build more strongly on the concept of our services being able to support our patients, regardless of which bit of the service we do develop. There will always be, and we could propose to continue to have, pan-North Wales services which are organised, managed and delivered across North Wales. Women's services, cancer services, diagnostic services and mental health will remain as, excuse me while I just put my power in, will remain as services that are provided across all of North Wales. And where we have existing services that are located within a specialist service located within a particular hospital site, we're not intending to disturb those arrangements on the back of this particular change. Next slide, please. So, as I've said, we will focus on our health communities being accountable for assuring a focus on population prevention and public health. We want to create opportunities for those health communities to be more responsible for a fuller range of services. So to put estates and hospital cleaning services under the direct oversight of each of our place bases. But we want to make sure, for reasons of consistency of care, that there are some aspects of service provision which we want to move to manage across all of North Wales. An example of that would be to create a single BCUHB-wide waiting list for the management of patients who are currently on a waiting list for planned care. And that takes us back to our comments earlier on about the importance of a single patient administration system for North Wales. We also want to build more strongly on our population-based approaches to think about the opportunities for developing multidisciplinary education for all of our clinical professionals and our other staff, much more as the norm, because that replicates clinical practice. And a small but significant change in moving the name of corporate functions to reflect the fact that those services are important services in support of frontline delivery. Next slide. Some things do say the same. I've already spoken about some of those issues in previous discussions, so I'll move on to the next slide. We have a phased delivery approach around how we may want to implement our operating model, and we're continuing to have conversations as part of our integrated board with regard to governance of the same, including a discussion later on this afternoon. Next slide, please. We're not there in all aspects of our operating model. There are some services where we needed to spend a little bit more time to think about the detail of how best they would be managed. And I've outlined those on this slide. We want to make sure that we're getting it right for these services. Next slide, please. And there's work to do within our corporate functions to think about how they can be refocused to service support where that's appropriate, with the concept of increasingly asking colleagues to be business partnered into the business whilst retaining a strong professional link into our corporate services. Next slide, please. I've mentioned the work that we need to do in the detail around governance, and the next phase of that are conversations this afternoon with colleagues. Next slide, please. And then just on to next steps before we fall into questions. Obviously, we've got timelines. Those are outlined on this slide. We've got a very tightly managed implementation plan with a fully documented risk register with mitigations in place, because making these sorts of changes bring opportunities but also need to be managed very carefully. Next slide. one of the things that is important around organisational change and change in the way we organise ourselves is to support the organisation through that change, and to make sure our existing new teams are provided with help and support to enable them to work in the different ways that the operating model does assume. Thank you, Sue. Next one. Finally, Jackie, apologies for going through very quickly, an opportunity to ask any questions, Jackie and Mark. Thank you.
Thanks, Jack. That was a bit of a canter, Jackie. We have got a board workshop at 1 to further discuss some of that which Joe described and highlighted. But any questions? I can't see any hands, Jackie, but I don't know if you or Jeff have got any questions.
Hugh's got his hand up, Mark.
Yes, no, yeah. Okay, Hugh.
Yeah, thanks for that. I'm just wondering, that's got a high level expectation. How will that be filtered through the whole organisation to different levels? And how will managers help you deliver on that?
Thank you, Hugh. You're a little bit crackly on reception, but I think you were asking about communication and engagement plans. So, yeah. We've developed the approach that I outlined on the back of an extensive communication and engagement plan with staff. And when we're almost at the stage, subject to some of the conversations that we need to continue to have, including this afternoon, to be ready to recommence that communication and engagement, those communication and engagement processes. That's not to say we haven't been keeping the organisation abreast and informed whilst we're in this consideration phase. We have been doing so. And I'm pleased to say, in partnership with Helen and the executive team, we have a detailed involvement and engagement plan in place. And I would just like to acknowledge the contribution that one of our IMs, Jackie, has made to thinking about what would be good things to do as part of the next phase. I'm very happy to share that with CHC and IM colleagues at an appropriate moment, and perhaps with Jackie's support, as Helen joins Nick on the discussion around the clinical services plan, we could also ask for an update on engagement to CHC colleagues in that setting. And of course, for board colleagues, there will be other opportunities to provide that more detailed information and assurance. Thank you, Hugh.
Thanks, Joe. I think that's an excellent idea. Quite happy to accommodate that.
Thank you.
So I'm conscious of time, Jackie. Should we move to the last item?
Yes, Mark.
It was 12:30, Fraser.
Yeah.
Important subject, but can we try and do it justice, perhaps within 10 minutes, Fraser, please?
Okay, I'll do my best. Thank you, Jackie and Mark. I'll speak in English, happy to take questions in Welsh or English. And I'm hoping Chris can help me drive the presentation, as I have a bandwidth problems here in Carlton Court with Zoom. So this presentation really is just to provide you with an update. And I'm hoping that we're linking in with you in CHC, and Mike, Alberto and Ian I know are in touch. So please don't hesitate to contact us if there's any more detail that you require. It's been a busy few months in mental health and learning disabilities team. The focus in this meeting today is on mental health, but happy to talk through some of the learning disabilities work in a future meeting if that would help at all. If I move on to the first slide, please, Chris, thank you. I think one of the biggest things I'd probably want to highlight is that we're trying to take a new approach to our work in mental health, driven in part by the recent incidents and key reports that have come out, and also thanks to the challenge from partners and within the health board that our improvements focus needs to be driving our work in mental health. There are some real green shoots out there, but of course we know we've still got challenges. But rather than try to deal with each individually, we have taken a helicopter approach, very busy diagram in front of you, but we are trying to look at all the issues, and with the support of the transformation team and Paolo and Chris especially, work through them in a more strategic and tactical approach. So we have a whole mental health improvement approach within the division, and that it's consistent and that the teams can see how it's working. If I move to the next slide, Chris, please, then here's one very early descriptor of the improvement work and how we're moving it forward. And actually it's already moved on slightly from this, because as a team we've worked with our senior team colleagues because we want them to own this with us, and we've now put in some foundational elements. But in essence, we are working through the key elements that we need to have improvement plans for, work through them so that it is consistent across the division, but at the end of the day that it will improve our care of the patients, because that is the driving factor for everyone. You'll see on the side there the approaches that we're putting the patients first, that we're looking for that continuous improvement cycle rather than a rather stop-start approach we've had in the past. And actually we want to reduce the variations in our teams, because we do have good practice, but we are not seeing it enough consistently. And then on the other side of the house, you will see the evidence-informed approach that we are taking, and that we are trying to make sure that we work through these and all the elements that we need to undertake. So do we need them embedded in the team? Yes. Are there elements that need to be just consistent, that we can work on our engagement, communication? Things that need to be about owning the space within the division, but then actually how we work collaboratively internally within the health board. And I think we are doing that and grateful for everyone's support in the health board, but equally with partners, and the CHC is a key partner for us. So this is new work, and happy to discuss this in any meeting, and I'm sure Ian and Mike will share some of this with you if that would be helpful. I'll move to the next slide if I may, Chris, please. Thank you. We have in the improvements work started to be a bit more finessed in terms of our work. So we are looking at short, medium and longer term objectives. I have to say, given some of our capacity challenges just now, the focus really has been on the short term, but we are through the TI work, of course, making sure that some of that medium, longer term work is progressing, and you heard Simon speak earlier. For me, in the short term at the moment, the improvement plan is key. We're not where we should be, and I know it's not where Lucy would want us to be from a QSE perspective, but we are making progress and working in partnership. Hergest is fragile in many ways, but there are some good pieces of work going on there. One of our biggest issues there is staffing and our recruitment challenges, and that goes right across the division. If I go to the next slide, please, Chris. One of the key areas that we really do want to move forward with, and are moving forward with, is the embedding sustained learning. This is something that's been raised in a number of arenas. The 7-minute briefings are doing well. I'm sure you know about the 7-minute briefings. I think they came from the FBI at some point, but we're using them in the team to drive those quick, factual conversations, spread the communications. They're working well, and we're using those through our operational services. We're now introducing the Oxford Model events, and we've got 2 of those to come soon. They're really shared learning events, whereby you kind of present facts, but you then throw it out to the team, senior and operational, to work through their thinking and some of the solutions. So it's like a pincer movement where you bring everyone together. Lots of success in England, and we're giving it a go, and so far so good. Learning events, we had a key learning event in November. That felt like a bit of a game changer. That was on therapeutic observations and engagement. And actually we've now producing a video to follow that up. So for those staff who couldn't be there, we're ensuring we're embedding and moving that learning forward. So it really is one of our key objectives. If I move to the next slide, Chris, please. So our priorities continue to be that stability piece. Governance is getting much tidier, but work still to do. On engagement, I'd like to think we're doing better, but with some capacity gaps just now, it's a challenge, but I hope that they'll move forward soon. The structure we've alluded to already under the operating model. And then I've mentioned the sustained learning. And of course, I think we've mentioned this before, and we're working on that OD package, which will be bespoke to the division. We need that. I'm grateful for Michael's support, Sue Green's team. really moving us forward. If I just move to the last few slides then, if I may, Chris, thank you. So in terms of risks, and we are really taking a risk-based approach, that first one is my biggest issue. I've got 140 vacancies. That's in nursing and other professions. I've got the doctors at 47. We're improving. We're still getting people coming in. Admin, I've got over 40. They're big numbers, as you can appreciate. And then when I looked at COVID figures today, we are making some progress in terms of COVID sickness. We were at 90 people off with COVID within the division. I think we're down to about 40 plus. So thankfully for the individuals and for the team improving, but you can understand the challenges then. And everyone supporting each other, but look forward to working with Sue and the team to move that recruitment strategy forward. We did have a virtual learning event recently, and we'll see now as people come through the application process whether we'll need to repeat that, but it felt good at the time. Poor estate, you've been doing your visits and I'm sure you'll have picked up the environmental factors, and I look forward to receiving your report. But you've seen Ablett and Hergest, and they are challenging areas to work in, but we are trying to do our best, and I'll come back to that on environmental. We do believe that there'll be an increase in demand still coming through the system. We've seen an increase in demand, but with some of the cost of living concerns, I can only see that going up from my public health perspective. The transformation work has been welcomed by the team and has given people a new appetite and energy. Although people are tired, so that's helpful. And then I won't dwell today on the mental health measure, but I know I reported the other day in one of the meetings in terms of our performance. We've struggled in a few areas because of demand and winter pressures, but we have some action plans to, again, get us back on track in terms of 1A and 1B. Last few slides now, if I may. So moving forward, the wellness workerness, which is a piece of work we've done to support the management with team issues, is really, I think, giving us a good approach. When I look at PADA rates, they've improved. When I look at sickness, while the rates are much too high, I admit, we have seen reductions in some areas, such as in stress, depression, anxiety. I could talk about mixed cohorting. I think Ian's presented to you on this. We've gone through phase 1, really. We're kind of moving into phase 2. Slight delay there, but that's due to some court of protection proceedings. But we do have a plan. And while I acknowledge fully we took some of the decisions from a patient safety perspective, we now need to do good on all those obligations that we have. And we'll continue to work with you and our planning colleagues to get it right. I think from my perspective, I'm glad that we've made a change that hopefully will be the right change for all our population in the future. We welcome your visits, your eyes and ears, your even smelling the arenas, you know, that kind of physical presence of yourselves. We welcome that. I won't go over it again here. We are making good progress in terms of that environmental work. I know that you have reported on more than one occasion about how some of our sites feel austere, some of those estates issues, but we have made headway, whether they're with the sunshades, some of the harm reduction work we're doing, even the Wi-Fi, and I thanks to Dylan and his team in taking that forward, some of the non-smoking work that we need to move on before September, and the gardens and even arts work. Ablett and our capital is still key for us in terms of estates. I need Ablett to move forward. We await Welsh Government feedback. The crisis pathway work, we're undertaking a review of our position given a national document. I think that will steer us in a positive way forward. And of course, the Stronger Together work, which touches on the operating model. I think that bespoke OD piece of work will make a difference for us. So to some pictures next, Chris, very quickly. Given that conversation around austere environments, our teams have been working with the arts teams. And Hedvan, as you enter it, I hope you'll see that we are trying to make it slightly warmer. I know if Jill were here, she'd be telling me about IPC. But at the end of the day, while we need to provide a safe, caring environment, at the end, for many of our patients, they are there for some time. And we need to find that fine balance. And I know you challenge us on that. And I think we're making some progress, but we'll continue to work with you. On the next one, if I may, I just wanted to show Coed Celyn, one of the estates, where we reduced our plot size in a way, given some conversations. But actually, thanks to estates work, it's really tidied up the space and now makes it a more welcoming area. I'd like to think we continue with this work. And again, we'll work with you where we can on all these, because I do think it makes a difference. So last, and I'm sorry, I'm going so fast. The last slide, if I may then, Chris, is just on some of our accomplishments. And we have really worked hard on that wellness work in us, the early intervention SMS and eating disorders and targeted intervention work. And we have ended now that mixed cohorting in Hergest. My final ask of you would be that we are receiving some funds from Welsh Government, and there is an ask that we work with our partners, and I'd like to work with you in the CHC, very tight deadline of about 2 weeks. And I know that Ian and Mike would like to make contact with you, and I'm happy to be in those discussions and just talk through some of our thinking and just get your views. So maybe I should stop there. Thank Chris for driving the slides today due to my IT issues in this office. But thank you, and I'll take questions. And I cymryd cwestiynau. Diolch yn fawr iawn I chi.
Thank you, Teresa. Whistle stop tour, but I appreciate the time constraints that you're working under now, especially I know you've all got meetings this afternoon. Jeff has got a very quick question, if that's all right.
Just going back to the fishbone diagram, certainly on leadership, much of that was in Holden and subsequent reports and is still unresolved. In terms of process, quality of investigation, sharing information seen as a burden, not at all. If you go through Ockenden 2, you will find a senior manager still in post who said that investigation of SUIs in mental health wards was a complete waste of time. That's his words, not mine. In some ways, the CHC acts as a organisational memory because of the flow of people in and out. I think it would be useful to meet with Mike and Ian and Teresa just to discuss. We haven't got time to go through it right now, but very much appreciate the offer to speak with you directly.
Thank you. Then if I may respond then, Jackie, happily do that. And actually maybe we can use it as an opportunity to discuss some of our funding discussions, but very happy to have that discussion, Jackie and Jeff, and appreciate your insight and knowledge and history.
Thanks. Perhaps once we've, Joy and I have passed on our report to Jeff and Carol and it's been looked at, some of the issues that we've found, we could discuss at that same meeting.
Thank you.
Thank you.
Right. Thanks very much, Teresa. Thanks, Mark. I think that brings us to the end of our meeting today.
It does, Jackie. Thank you. And thanks for the time that you and your colleagues have invested in meeting with us today, and also for your continued role in ensuring that we focus on our patients and try and deliver best services that we can.
Thanks, Mark.
Thank you.
Our next meeting is in October, and it could potentially be the last meeting of us as the CHC before we go over to the new Citizens' Voice. But we'll know more nearer the time of that meeting. So thank you all very much and look forward to seeing you in October. Thank you.
Thank you. Diolch yn fawr iawn.